evening, Area Express viewers. We have special guests tonight for you. We have three guests. I'll let them introduce themselves briefly, and then we'll talk about the works that they did in Eritrea, how it started, and then we'll see their reaction first. So we'll start with Dr. Poland, and the way I see it in this, and then we'll go to Dr. Abrin, and then to Melba. So briefly, if you can introduce, and let's start with that.
Well, it's a pleasure to be here. I, at the time this program started, was the chairman of OBGYN at Stanford, and had been actually at Berkeley, at UC Berkeley, getting a master's in public health. And the person who I spoke to about doing the paper that we had to do to get the degree was Haile DeBoss, who was the chairman of surgery, of the Department of Surgery at UCSF, and Eritrean. And I asked him about his country, and he said I should go to Eritrea. So I contacted somebody that he knew, and we were invited to come to Asmara, and we did. That's how it all got started. Subsequently, I left Stanford, moved to New York, was on the faculty at Columbia for, probably 4 years, and am now back at Yale, where I went to medical school and did my residency and fellowship. And so I still see patients and commute between Connecticut and New York.
Okay, Dr. Abrin.
Hi, and thank you for having me. I'm very excited to talk about the work that we've done in Eritrea over the last almost 20 years. And along with Dr. Poland, as part of the Eritrean Women's Project, I am a urogynecologist and fistula surgeon, and have been working with the fistula program in Eritrea since 2007. So it's been a long time, over many years, and it's been really wonderful to watch it grow and develop into a really integral part of the healthcare systems in Eritrea. It's been wonderful to work with the medical students, the residency program, and the surgeons that we've worked with in Mendefera now for the last, almost 14, 15 years in Mendefera specifically. So again, really happy to be here to talk about our experience with this project.
Thank you. And Melba?
Hello, everyone. My name is Melba Williams-Kirk, and I am a filmmaker, also an educator at Middle Tennessee State University. And I am involved in this project because Dr. Poland invited, she was looking for a student to come and document the work that they were doing there in Eritrea. And at the time, I was in the MA documentary program at Stanford. And so it ended up being my thesis project, and we worked on it for a year in pre-production for the entire year, those 2 semesters, and shot for, I believe, 10 to 11 days.
Right.
Yeah.
It was a wonderful 2-week trip.
Yeah, and that was actually my first time going to Africa. So I was absolutely thrilled to work on the project and just really, really appreciate the work that everyone was doing. So I'm glad to be here to share our experience.
You had someone with you too, right? It's not only you.
Yeah. Yes, we each in the program at that time, I'm not sure how it is now, but I'm sure it's quite similar, but we all have to crew on each other's film. And Carla Gutierrez, who is now a critically acclaimed award-winning editor, documentary editor, yes. She came along and she did sound. So it was Carla and I from our program.
So Dr. Poland, how did you come up with the idea of being this documentary or being recorded? Because I think you might have helped Melba. Like people writing for PhD or masters, they always have like a hiccup or like as to what the title is or what subject and so forth. So by asking her, I think you kind of help her with the
Well,
how did it come up?
we wanted to document it. And I really wanted to do it visually. We've written papers and published papers on the outcome of the surgeries and the kinds of surgeries, but that's medical literature. The country is beautiful, the people are lovely, and unless you can see it and watch it, you don't get that sense. And so I really wanted to document it as a film. And I had been going to Sundance, to the film festival at Sundance, and I thought, well, Stanford has a film school. You know, there have to be students. They have to be doing a thesis. Maybe somebody's interested, because we raised money so we could supply airplane tickets to people, but the Ministry of Health housed us and fed us. And I didn't have any funding to hire somebody to do a film. So I thought, well, students, in the first place, a student would love this, I think. And so I went to the school, and Melba, I don't actually remember who gave me your name, but somebody told me to call you. So I did.
It was either Jan Krawitz or Christine Samuelson.
I think it was Christine Samuelson. That rings a bell.
Right? Yep. Yep.
That actually came up pretty good, because I watched the Mend at your graduation. It's well done, and I think it's a good documentary. But to go back to what you did in Eritrea, you were involved with the Fistula program. So for people who don't know about Fistula, what is Fistula? What is the effect of it on women's health and on the society and so forth? So if you can briefly talk about that, because
I think Ambreen is the best person to answer that question as a GYN urologist.
Mm-hmm. Okay.
Well, I'm happy to talk about the condition. It's an important one that we need to know about. Fistula is a condition that affects women who don't have access to emergency obstetric care, and it is a result of obstructed labor. So women who go into labor who end up getting obstructed, meaning that for some reason the baby isn't able to be delivered vaginally and they need some form of intervention, usually a C-section, can't get it. And there are many reasons why that's not available. And, it's complex, but kind of simple also. And so it ends up resulting in really severe pelvic trauma. And the resulting condition leads to chronic incontinence of urine, chronic incontinence of feces sometimes, and it can be remarkably devastating for somebody who's going through this condition. But also it results, the obstructed labor results in stillbirth in over 90% of the time, because at this point, the newborn or the baby is deprived of oxygen. And so, it's devastating. And the cure in most instances is surgical. Not all can be cured with surgery. And some, if caught early and are small, the damage can be cured without surgery early on, but that's also not so common. And we sort of consider it it's not just about the damage done, but it's the sort of extenuating circumstances that result. The relationship with the husband or partner, the relationship with the family, the relationship with the society and the structure, and how a woman who's suffering with this condition can interact now if she wants to. The social stigma, the mental health challenges, the physical trauma is not just in the pelvis. We call it like a field injury because it's extensive. So that's a little bit about the actual condition of obstetric fistula. We don't have it in the United States or in Western countries where a C-section is readily available or emergency obstetric care is available. But I also think it would be interesting for Dr. Poland for you to talk about how that even came up as with your interactions with the Eritrean Ministry of Health, how that ended up becoming an issue for you to help them with?
Well, it's sort of a circuitous route. When I first got in touch with the physician in Eritrea, it was in Massawa. Dr. DeBoss sent me to somebody who was worked in Massawa at the hospital. And as those of you who've been there know, it sits right on the Red Sea. It is a beautiful view. And so I contacted him and said that I told him what I thought we should study, that we should study contraception. Because at that point, I knew that in Eritrea, people were given condoms in the hotel rooms, like they are in the United States. And I thought that was interesting and perhaps unusual in a country that was a third Catholic, a third just plain Christian, and a third Muslim. So I thought that would be an interesting topic to look at contraception. And I was immediately told by Dr. Mecki that that was not what we should study, that what we needed to do was look at fistula, because that was the biggest problem. And for those of you who knew Dr. Mecki, you didn't tell him, I don't think so. I think I want to do something else. He told you what to do. And I got that pretty fast. So I said, fine, we'll do fistula. But I am a reproductive endocrinologist. I get people pregnant. And at that point was not delivering babies. So I had to quickly find people who could deal with fistulas. And the people who do that are the urogynecologists. And at the time, we didn't have somebody at Stanford who could do that. We had GYN oncologists. And the guys who do the cancer care operate on the bladder and the ureters and do urologic surgery too. So I, at that point, went to Amreen Hussein, who was a GYN oncologist, and she came with us on the early trips because we didn't have a urogynecologist. And so I didn't actually choose what we did. Dr. Mecki chose what we were going to study. And of course, when we got there, as Melba can tell you, it was very clear that he was right. And that was the most important thing, because it is, as Ambreen has said, such a devastating condition. So we sort of fell into it. I knew about fistula. And actually, there are rare fistulas in this country, usually from cancer care or radiation damage. But in the early 1800s, when people were just beginning to do obstetrics, even in this country, there were no cesarean sections, and there were fistulas that occurred in the United States. So the fact that there aren't any more in Western Europe or the United States is strictly an historical improvement. That's what happens anywhere if you don't have cesarean sections. But I think we were fortunate to discover this as a topic.
So how widespread is it in other parts of the world besides Western Europe and in Asia, for example? Or does it have to do with religion, or what does it have? I mean, is there any connection with religion or any other besides,
Well, there have been statements that female circumcision is one of the things that causes fistulas. Mm-hmm. And I'd like to hear what Ambreen says. I don't think it per se causes fistulas. I think it predisposes to protracted labor. Mm. But so you go ahead, Ambreen.
Oh, sure. No, there's no, the root cause is inability to get emergency obstetric care. So it could be economic reasons, it could be cultural reasons. There's no religious reason. And as far as, FGM or circumcision, only in the most severe form, which is not common, has there maybe an association between protracted labor. But as far as the association, it's not there. People try to make it there, and they try to make a connection with religion. Mm-hmm. They try to make a lot of connections with other things, but ultimately, it really is lack of emergency obstetric care. It's considered a barometer of the healthcare system, and in areas of the world which have had challenges to building up a healthcare system, whether it's internally realized or from external forces, this is one of the outcomes that you see. So that's what I would want to say about that, as far as the reasons for it. You know,
I'm glad you answered it that way. But
one of the things that really struck me once we got there was just the region itself. And so I could see how it would be so prominent in this particular side of the world because it's in the highlands. And so I remember when we traveled, I think to Adikaye, and just seeing, it sort of looks like the background you have there, Isaias, but
far from
so remote that I didn't understand until I saw it, like, oh, this is how a woman ends up pregnant and in labor for 3 to 4 days, because just having to travel to the nearest medical center is extremely taxing. And so
yeah. So Melba, have you heard before you went there, have you heard of Fistula, and what was when you heard that, what was the reaction? And when you went there, you started mentioning when you the first time, how did you plan it and all that? I mean, how were you?
No, I had not heard anything about it. And Dr. Poland gave me an education on it. She explained it to me and, directed me to different reading materials. And so I did my best to understand it and also research the country as well and try to understand the region and, just some of the conditions and social behaviors and things like that before we left. But of course, it's always beyond what you imagine. And it's a beautiful country, and the people are just so beautiful and welcoming and endearing. And it was amazing to me that the women were suffering with this experience. I have a clip also, and I think you may want to, I have a clip. So I don't know, if you want me to share it, I can, but it was really heartbreaking to see, and just to see the people. I knew they would be coming to the hospital to try to get the surgery, but I remember the day that we filmed at the hospital, just the desperation that people really wanted. They understood that this could really change the outcome of their lives, and so it was incredible. It's an incredible experience.
So you went twice or once?
No, just once.
Oh, okay. So you went, and then how did you? There were 2 sisters in the film, if I remember.
Yes.
How did you pick those?
And our contact there was Dr. Abrahat. And I was on one of the trips with Dr. Amreen. So I remember trying to get in touch with Dr. Abrahat, and I don't know who ever did before. It was, cat and mouse for a long time. And then we finally met once I arrived, and she had everything planned out. She had identified women that she felt like their stories, would fit the profile, because we wanted to show the region where many of the women came from, and just how, how rural it was. And also, could build a story from. And so began with their hometown and then followed them to Massawa, to the hospital. So Dr. Abrahat, she had already identified 2 different stories. So one woman was Christian, and then the 2 sisters were Muslim. And we did interview the first woman, but she was not going to get the surgery. But the 2 sisters, they had saved money, I believe, for the journey. And so we were able to follow them from Adikaye to Massawa.
So Dr. Abri, is there a relapse, or is it, because I've heard when I was there that there were I don't know if you, I don't know the number, but came for surgery again. Does it happen often, or doesn't? And why would that happen if it's?
Yes, I think the popular narrative is that it's a simple surgery that takes less than an hour and will change a life. And the reality of the situation is that most often it's not a simple surgery, and it needs to be done by somebody who's been specifically trained in obstetric fistula surgery. It is often quite complex, and there is a failure rate of approximately, sometimes 30, sometimes 35% if the damage is extensive. Some women are very lucky, and due to circumstance and due to many different factors, their fistulas are more what we consider straightforward. I will never say it's simple, because it's never simple, but let's say straightforward. But by and large, many are complex. And again, the first surgery is your best chance of healing. So it needs to be, of course, done by somebody who is trained in this particular repair. And also, just to follow up a little on Dr. Poland's point, most urogynecologists in the United States are not trained in obstetric fistula surgery because we don't have them here.
They don't see it.
So we don't see it. Cancer surgeons see complex fistulas and are able to have a better understanding and come with the experience. But for somebody who's not a complex gynecologic oncologist or urologist, we don't have that experience. So our experience comes from working in big centers where this training happens. So I had to go through many years of training to be able to do this. So, one of the things about this project that I think was really remarkable is that the Ministry of Health, as well as all the partners, insisted that we had to train surgeons who were interested in this. And so, over the course of almost 20 years, that the project that Mary Lake has established, that Dr. Poland has established, has really worked on training surgeons who can operate and who can also fix this condition. I think that was really important.
Well,
So,
to add to that,
yeah.
one of the things I wanted to do from the beginning is to work ourselves out of a job. The idea is not to have this as a long-term process. The idea is to train people in that country, in Eritrea, to do the surgery. And we were very fortunate because the government established a medical school while we were there. So we could train people, and we just rotated a whole group of people, urologic surgeons, filmmakers. We brought in physical therapists. We brought residents. I brought my daughter, who was an undergraduate at Stanford, who has turned into a dermatologist. She grew up. I mean, that was 15 years ago. So we brought all kinds of people who could help not just take care of the specific surgical procedure, but could teach people about exercises, could talk to them about lifestyle. And so the idea was to leave people who were trained to care for not just fistulas, but obstetrical care and postpartum care. And we haven't been back for almost 3 years now, for a variety of reasons, COVID predominantly. But the whole point is to leave a program that functions and generates its own surgeons and its own clinicians.
Dr. Aureen, you were going to say something.
Me?
Oh, were you going to say something?
I also wanted to bring up, the big portion, to have any surgery in a hospital takes an entire team, right? From admission to pre-op care, to nursing, to transport. And I can't tell you how important the nursing component is in this. And I have to say that some of our, Eritrean nurses are some of the best I have ever worked with. And they could literally write books on pre and post-op fistula care with their experience that they've had. So, again, also introducing medical students early on to the condition. So even if they don't go into this kind of work, whatever they go into, they'll at least know to look for it and know where to refer people. And once the national center was established in Mendefera, it became the place that all patients from around the country were sent. It had the surgeons that knew how to do the repairs. And over time, over 10, 15 years, you had our Eritrean surgeons were doing most of the surgeries, and we were there mostly working on incredibly complex cases. Again, the training never stops, just like any of our jobs, right? You constantly have to keep your skills up and keep improving. So we really saw a shift in the cases we would see and the numbers that would be done between the times that we would be there. And when we were there the most, we were there almost 4 times a year. So it was nice to be able to see progress happening.
Yeah. I mean, yeah, the changes, even on the news and stuff like that, in the beginning, different, but now, it's become in the news, and people and the statistics, always they bring out in the statistics, because the health, I think with the last report that they got is like 25% of the country's budget is spent on healthcare. So it's very, you can see.
That's huge.
It's huge, yeah. And so you can see why the health, especially women's health, because they're the backbone of the society and so forth, is very important. So I think we can see the changes and stuff like that. That's relevant to this program. And like you mentioned, the late Salim was very adamant into that, and then so it became his. So I think it's a very good idea that is centered in Mendefera and so forth. So, and to have it on the film also it's very important. But on the fun side of it, so when you went there, I know I've spoken with Dr. Paul, and we talked about snorkeling there, and also the grappa. Let's talk about grappa first. What is grappa? Because I've heard people saying Asmara beer is good, or the Asmara Arak is good, but people never heard of grappa. So what is grappa, and why you say, when we talked about it a long time ago, you mentioned it's the best grappa you had. So the measurement for it and stuff like that.
Well, we all know that Eritrea was an Italian colony. So there are wonderful coffee houses and beautiful Baroque Italian architecture, and wine, and grappa, which is sort of redistilled wine. And we were, and people make it at home. And so one of the places we went, because when we first started, there was no National Fistula Center. And so there were about 3 doctors doing fistula work. And we went from one place to another. And in one of them, one of the doctors had a bottle of distilled grappa in the back room and shared it with us. And it was just lovely. And I had really never had grappa. I now drink grappa occasionally because it's so good. And that brings up something that Amberine said, and Melba said it. Everybody was welcoming. This wasn't really work, for me at least. This was the ability to do something I love to do and to enjoy doing it with people who like doing it too. So it was a lovely place to go. As I said, I took my daughter, and we took medical students and residents and fellows because we could raise money for the travel. And I always thought that the more people who understood what this was all about and who could work in a situation like this in a developing world country, the better off everybody would be. Because in the United States, you work and you worry about billing and collections and coding and insurance and that sort of thing. Well, if you go to a place like Eritrea and you do fistula surgery, all you worry about is taking care of patients
Mm.
and helping their families. So you're freed from all the stuff that doctors don't really like to do anyway. And we never had any problem getting people who wanted to come. We had many more people who wanted to go with us than we could accommodate.
Mm. Okay. Any Melba or Dr. Aubrey? Anything on the fun part, or was just where?
Oh, the fun part, I mean, grappa is great, but once you're invited for SUA, that's another story, right?
Yeah. Yeah.
And I do think Asmara beer is, there was a time where you couldn't get it.
Yes.
There were a few, there were shortages at one point. There were no bottles, throughout the many years of going. But I think, being invited to our friends and family and to have like homebrew was really special too.
Anything that, that you did for fun when you were there?
Oh, I'm sorry.
From Andrei to
we had a pretty packed schedule.
yeah. It was 2 weeks.
We
Yeah.
travel in a short amount of time across the whole country, really. I remember, just seeing the landscape. I remember always a small town called Ginda, I believe.
Yeah.
Yeah. Going through there and how beautiful it was. It was very green. And probably the experience that sticks out in my mind is that curvy road that used to be a train would travel, I believe. But
it has the going from that was scary.
The road to Massawa.
The road to Massawa.
Yes, pretty scary traveling around that curved mountain. But yeah, we met friends there. Ironically, I remember the first one of the first students that we met at the university there had actually gone to graduate school with one of my best friends at University of Florida. And so, yeah, I had a lot of weird sort of connections like that, like meeting people that I would meet later on in life and sort of link back up with. So, which to me is always confirmation that you're in the right place at the right time. You're exactly where you were supposed to be. So, yeah.
So if you're going 3 times, 4 times a year, so you are going during different seasons, right? Where you going?
Well, we went when they told us that we could come. And it had to do with harvesting crops and when they needed people in the field. So we would always find out from the Ministry of Health when they thought, and they also had to have space in the hospital, and they had to have nursing staff and equipment. And so we didn't pick the times. We came when we were invited.
I'm glad because I was trying to say how did it happen that there was 3-4 times? Okay, it makes sense because since it's associated with rural life and all that. So I think
right.
So
and also
go ahead.
Also during religious holidays, everything had to be sort of take into account what everyday life was like. But yeah, definitely around harvest time, planting time, our schedule was figured out by the Ministry of Health as to when the best times were for the patients and for the hospital staff.
So a lot of collaboration with the Ministry of Health.
Oh, very close
Absolutely.
cooperation, yes. And remember, the post-op care in this country, people go home 3 or 4 days after surgery. That's not what happened. People stayed for a month post-operatively. So they had to have a protracted recovery time.
So they would go to family, or would they be associated with the hospital or in the hospital, or?
The whole family would come to the hospital, and the Ministry of Health would feed. The family would camp outside the hospital and then come in and help care for the patient. And the whole family would stay there while the patient recovered. So the whole family would move to whatever compound around the hospital the Ministry of Health had set up and stay there for a month and a half.
And also, Dr. Poland, the rehab center in Mendefera that was set up.
Oh, right. Yes, talk about that. That was new, and it was really a very helpful thing.
Right, right.
So if you can talk about the rehab, Dr. Ambry.
So the rehab center, some women would need a few months to recuperate, and with the Ministry of Health, Ministry of Education, and the hospital staff, there was a rehab center set up outside of Mendefera that Dr. Poland had helped establish. And it also gave a chance if women wanted to have some literacy education and training, vocational training, if they chose to participate. But it also gave a chance for women to really recover before they went home. Some women wanted to get back home once they were healed from the surgery, and other women needed more time. So it was a safe place for women after their surgery to spend some time.
So any, like you mentioned earlier, the surgery or going through it is life-changing. So is there any particular story that stood out for you that are complete life-changing? I mean, most of them, or all of them are like that, but any special or different that you heard? Or
honestly, there were so many people who I feel like they touched our lives also. We are one of the few groups in Eritrea, because we had such a long-term relationship with, that we were able to do a specific type of surgery called a urinary diversion, which is an extensive surgery that really needs long-term follow-up care, very close laboratory checks and such. And it was something that we were able to offer to a handful of patients who qualified for it. And I think one of the stories that really stuck with me are the women who were able to have this extensive surgery after basically they really didn't have any hope, and were able to get pregnant afterwards. And one of them had come back with her baby. So I think being able, not all women are able to get pregnant, but to be able to give some women that chance to start a family again. And so seeing those patients back, a handful of patients would stay and ended up working for the hospital as nursing assistants. And I think that was really remarkable to always be able to see some of your patients who now had a job and were able to, make a living. Others who had taken it, who wanted to opt for some post-rehabilitation training, either sewing or whatever they chose, started their own businesses nearby. And so we would see a lot of our patients again over time.
That's remarkable. How many Eritrean doctors are there trained to do the surgery now? In the beginning, you said there were how many in the beginning, and now how many are there?
In the beginning, actually, we dealt with two people, Dr. Lilty, a woman doctor, and the male doctor who ran the GYN wards at Asmar at the hospital.
Dr. Hopday, yeah.
So how many are there now?
So since that time, we would have, when the residency program started, we would have residents that would rotate with us. And then a couple of them had taken this on as something that they wanted to be involved with. One of them is with Dr. Hopday now in the Mendefera Regional Hospital, Dr. Dawit, who we do still work with and see. And I don't know, since we haven't been there for a while, how many other of the residents are still involved with the training. But they would during part of their rotation spend time in Mendefera, because that is the regional center, and get exposure and experience with this particular surgery.
So when COVID, and all of that is hopefully over, when do you plan to go back?
As soon as we're invited.
Okay, so yeah, I've worked with you in transcribing and all that, and I've read some of those scripts that people were saying or transcribing it. It's impressive things that you have been doing there. And the result of what you started is it's growing, and it's very helpful to the country. So I'd like really to thank you for what you've been doing, what you did, and continue to do. So I don't want to thank you for your time, because it was hard to rearrange the time and all that. Everybody's busy. So if there are any other last minute comments or that you want to add, I will give you that chance.
I'd like to say one thing that I think has been very important to me and to my family, because I brought my daughter, and I was remarried, and I brought my husband, my second husband, who has no medical background whatsoever, and thought it would be really terrible to watch somebody do vaginal surgery. But it's like watching a delivery. Once he was there, he was fascinated by it. And my daughter loved, all she did was transcribe the history. When Dr. Abrahet would question a patient, Lindsay would write it down. Mm-hmm. I think it's important, and Melba is a prime example of somebody with no medical training, mm-hmm. who came and functioned and enjoyed it and contributed. I think it's important not just to bring physicians. I think everybody should have this kind of experience, should understand what it means to go someplace and do something you love just because you love it, not because somebody's paying you, and not because you have to, but because you're doing something that is productive and it's fun and it makes you feel good about what you're doing. Mm-hmm. And that's not just for doctors, that's for everybody. Mm-hmm. Yeah. So as you bring people into the country, you can bring writers and filmmakers and plumbers and electricians. I think everybody should have that kind of experience.
I totally agree. Anyone, Dr. Aubrey, you want to add last minute? Mel?
Mm-hmm. Go ahead, Mel.
Oh, well, I would just want to thank Dr. Poland for allowing me and inviting me into the experience. And it was definitely one of the highlights of my experiences at Stanford. And so I just really appreciate it. And now being a mother, it really changed my whole perspective of healthcare in America here, and just how privileged we really are. When I hear women complain about this or that, or worrying about scheduling their C-section, I'm like, shh, no. No, you are extremely blessed. And so it's just, I just think that it's amazing what you establish, and it's also amazing to see what can happen when people work together. So.
Well, it was a pleasure, Melba. It was wonderful having you.
Wish I was there, Melba.
Yeah.
I must have come after.
Yeah, I was 2004.
Yeah, just after. Yeah. Isaias, I did want to say that, the experience for me, for the many years that I've been involved with this project, really solidified the idea of collaboration and working with ministries of health, working with the National Union of Eritrean Women, working with the Department of Education, and really getting a partnership with the regional hospital, with our surgeons that we worked with nursing. And I think that the model of, really like a long-term commitment with surgical training, which is a transferable skill. It's something that when you start with somebody who's interested, who has, medical knowledge, but mostly the commitment to learn, you can really have a very successful partnership. And I do think that the partnership and collaboration in Eritrea, for me, was really a model. So when I started International Medical Response, which I've been doing now for almost 5 years full time, in working with surgical programs in different countries. This has been the model for me of how to create a real partnership with equity. And I think that that was really important. And I think that's one of my biggest takeaways from the many years of working in Eritrea, was how to have an equitable partnership in healthcare with again, all the people that make it happen, including the patients. So I think that that was really a really important part of my education.
Glad you mentioned that, because I mean, it's equitable, partnership is important for economic development and health care and education and so forth. So I think you're right. So as you know, it's your home country away from home, so you're welcome anytime. We make sure that you're invited. You don't have to be invited. You can come. You can go anytime. But I would like to really thank you for what you've been doing, what you continue to do, and then thank you also for your time tonight.
Well, thank you for having us and allowing us to talk about it.
Now, I mean, your work needs to be told, and people need to. I mean, some people have read it, but it needs to be like visual and so forth. So, so thank you so much.